Now, just to end the presentation, I'd like to present some data on the use of Lurbinectedin in Australia, Zepzelca access program, and these patients were treated under an access program. There were 62 patients as of August this year that were on the program. You can see that there's an age range up to 83. Around half of patients male. If you looked at this 20 years ago, just about all of the patients would be male. So small cell has become relatively more common in females. 3/4 of the patients performance status 1, and a relatively small group of patients with worse performance status. CNS metastases in about 1/3 of patients, and half with liver metastases. These were generally extensive stage patients. The number of prior therapies, 60% had one prior therapy only, so treated in the second line, and then 1/4 of patients treated in the third line setting. And we can see that there's a group of patients who relapsed early, 15 patients, 24% of patients relapsing early. About half of patients staying on treatment, or rather the chemotherapy-free interval greater than 3 months. So it's about half of patients there. And again, about 1/4 of patients having overall a chemotherapy-free interval less than 90 days. Looking at that in terms of the duration of that patients stayed on treatment, so we haven't actually analysed for response yet. We can see there's a group of patients that have been only on for a fairly short period of time, and then there's other groups of patients where you might expect that they must be benefiting from the treatment because they're staying on for 6 to 12 months. And just one thing we had looked at in terms of the patients in the therapy-free interval, short chemotherapy-free interval, we could see that generally more of these patients, about twice as many patients, were in the short duration treatment. In other words, they relapsed early on Lurbinectedin, and as compared with, for example, the patients who are on longer period of time. So the early patients who had only treated shortly after the cessation of chemotherapy didn't do so well. Thank you very much.
Thank you, Dr. Michel, for the excellent talk. So thank you for summarizing the first-line treatment landscape in extensive stage small cell lung cancer. If you have any questions, please leave them in the chat section, and we will discuss them at the end during the panel discussion. We will now move on to our second talk on systemic therapy options following first-line treatment of small cell lung cancer by Dr. Santiago Pons. Dr. Pons is a medical oncologist in charge of the thoracic tumor unit of Hospital 12 of Octubre. I'm not sure whether I'm pronouncing that right. For the last 10 years, he's been involved in clinical research, especially dedicated to small cell lung cancer and targeted therapies development. Similarly, he developed the molecular profile program of lung cancer at the molecular tumor board at the same hospital. He has contributed to numerous peer-reviewed publications, and he's also the scientific coordinator of the OncoServe Foundation, dedicated to the promotion of medical education and independent clinical research. Currently, he's working at the Institut Gustave Roussy in France in the Department of Therapeutic Innovation and Early Trials. Over to you, Dr. Pons.
We're coming to Lurbinectedin, that actually I think is one of the main issues that we have in small cell lung cancer. You know that Lurbinectedin is an inhibitor of the transcription factors Also, lurbinectedin, we have some immune activity with induction of the cell proliferation, inducing interleukin 6 and interleukin 8. We have an inhibition of the immune response activation checkpoints. And also we have induction of angiogenesis that we were checking in the Chinese trial, that the angiogenesis maybe is playing a role in small cell lung cancer. We have this phase basket trial with lurbinectedin with small cell lung cancer that was published in Lancet Oncology last year, with a dose of lurbinectedin 3.2 milligram per meter square, that we have for the progression-free survival with a median progression-free survival of 4.1 months, and for overall survival around 1 year for those patients. The response rate is quite encouraging for monotherapy. You can see the first plot here with a huge 67% of the patient having partial response, stable disease also, and clinical benefit ranging for more than half of the patient. The disease control rate, around 73% of the patient having a control of the disease when we treat with monotherapy with lurbinectedin. As I say, PFS around 4 months and overall survival around 1 year for second-line treatment for those patients. The adverse event profile for lurbinectedin is well known. It's mainly hematological. It's mainly anemia, thrombocytopenia, and neutropenia. It's easy to manage in monotherapy that and probably we have to do an effort to keep the doses of lurbinectedin, maybe also using factors, because we know that the exposure to lurbinectedin is directly related to the response rate. So it would be better to keep a good dose of lurbinectedin in that case. We have this Atlantis trial comparing lurbinectedin plus doxorubicin versus CAF, adriamycin, cyclophosphamide, vincristine, or topotecan, that is not positive for overall survival. These are the data that we are going to publish soon. We don't have any advantage except for probably the toxicity, and we are probably doing new trials to check in a phase 3 manner the effect of lurbinectedin alone over the small cell lung cancer. We have some other approach. This is the Resilient trial. This is a trial, a phase 1 trial, also checking irinotecan pegylated, checking 2 doses of this 85 and 70 milligram per meter square. We have some preliminary data that are going to be published also in a paper in a few weeks. The response rate is also very encouraging. Partial response around 43% of the patients, stable disease 26%, and objective response rate in total quite encouraging, and more important benefit for this treatment, 72% of the patient harboring some kind of activity for Naliri, that is the irinotecan pegylated. This is an example from our center with a liver disease with a very good activity of this drug. Regarding toxicity, as with lurbinectedin, the main toxicity is hematological toxicity, mainly neutropenia in the day 8 of the liposomal irinotecan. But to my knowledge also is a very good toxicity profile and may represent a new option for those patients in the future. Median PFS 3.9 months and median overall survival in this phase 1, 8 months. Please don't post this result because they are not already published. We have also another idea of combination of irinotecan that for sure is a good option, plus lurbinectedin. And we published this phase 1 trial, multi-cohort trial, but with a lot of patients with small cell lung cancer, 21 patients, checking the efficacy of lurbinectedin, in that case 2 milligram per meter squared, that was the research dose, plus irinotecan 75 milligram per meter squared, plus GCCF. As I said, it's important to keep the doses of lurbinectedin. And we have that for all the patients, the overall response rate is 72% of the patient. Clinical benefit, partial response plus a stable disease, 81% of the patient. Disease control rate, near 90% of the patient. Median duration of the response, 6 months, and median PFS around 6 months. It's very encouraging, the data that we have for patients with refractory disease also. This is a very tough population. We have only 8 patients, but with an overall response rate of 50%. So it's quite good from my point of view, and probably one of the best options for those patients with refractory platinum disease. From the point of view of toxicity, is adding toxicity from the hematological point of view. That is the reason that we are treating with a primary prophylaxis of factors. Some other lab abnormalities, like liver abnormalities, but really no death related to the treatment and feasible to do this approach. This is in a beautiful manner, the waterfall of the response of those patients with a partial response and stable disease closing to 86% of the patient. Importantly, if we look for those patients with a good response or bad response at the beginning, we have activity for both of them with a combination of Lurbi plus irinotecan. And we're going to finish with a trial that we published last week. Actually, it's a phase 1 trial also, combining atezolizumab plus lurbinectedin. Lurbinectedin in an escalation manner, 2.5 plus atezolizumab fixed dose, and then the monotherapy doses, 3.2 milligram per meter square plus atezolizumab at the fixed dose. The primary objective of this trial in the phase 1 is the research to research a dose for combining atezo plus lurbinectedin, and the final dose that we have is 3.2 milligram per meter square. And secondary objectives is response rate and progression-free survival. This is the characteristic of the patient. We only have here second-line patient. In that case, we only have here patient immune naive. But the trial is going to have a phase 2 part with more than 150 patients, including immune previously treated patients. This is the toxicity profile. Actually, hematological toxicity is remarkable, again, like in every lurbinectedin trial. And actually, the recommended dose is 3.2 milligram per meter square plus primary prophylaxis of factors due to this toxicity and to avoid decreasing the doses of lurbinectedin. Regarding the activity, we are quite happy because we have 7.7% of the patient with complete response, partial response 50% of the patients, stable disease 26.9% of the patient, disease control rate of 84% of the patient. Actually, this is really, really encouraging for us. PFS is not mature. We have a PFS of dose level 1 with 7 months, and with the dose level 2, that is the 3.2 milligram for lurbinectedin, is not yet mature. We have 4.4 months for this. This is the waterfall of the patient with different levels, with 2.5, 3.2, and 3.2 plus primary prophylaxis. As you see, we have a lot of patients with good response, complete response also, and those patients responding with a very long duration of the response. So probably we are going to have more data for this combination for second line, pure second line, and we are going to have also, is going to start a trial with the strategy of maintenance, platinum plus immune therapy first line, and then starting a therapy for maintenance with lurbinectedin plus atezolizumab following this schema. As a take-home message from my point of view, it's clear that chemoimmunotherapy is the standard of care for first line. In the second line, we have a variability of alternatives. We have the rechallenge of platinum, but sure that lurbinectedin has a very good activity in the second line alone or second line in combination. And from my point of view, lurbinectedin is the standard second line right now for our patients. Irinotecan, pegylated or in combination with lurbinectedin, emerge as a potential alternative, mainly the combination with lurbinectedin for those patients having a platinum refractory disease. And current approaches combining immune therapy and chemotherapy and different strategies like a target therapy, like the Notch B-specific antibody may improve the outcome of our patients. Thank you so much. These are my email from my two institutions. Thank you so much.
In the second line setting onwards, there are now two preferred regimens, either use of topotecan or now lurbinectedin. And there are multiple other agents that have been tested in early phase trials, in phase 2 setting largely, which can be used both available as IV and oral agents, as well as immune checkpoint inhibitors, pembrolizumab and nivolumab. A few key points to highlight in what we currently understand about how lurbinectedin may play a role in a patient's life. This drug is now approved for use as a single agent on the back of a clinical trial, a phase 2 study, which showed an overall response rate of 35% amongst 105 patients, with a median duration response about 5 months, with cytopenias being the main side effects. And this was given in the setting of patients who had received platinum-based chemotherapy in the first-line setting. In a phase 3 clinical trial called Atlantis, lurbinectedin was combined with doxorubicin and compared against CAV or CA plus topotecan. While it missed its primary endpoint, it demonstrated tolerability and overall activity in patients. One previous speaker has talked about the combination of irinotecan and lurbinectedin, and this combination will progress into further stage, advanced stage clinical trials and appears to be promising thus far. 3 early phase ongoing trials that combine immunotherapy with lurbinectedin will be informative for how we can combine immune checkpoint inhibition with lurbinectedin in the setting of patients who have received first-line treatment. Beyond these drugs that we've mentioned, there are other treatments that are on the horizon, and there are some challenges with some of what has already been tested. While I mentioned earlier the loss of p53, RB1 proteins, and the amplification of MYC is very common in small cell lung cancer, these pathways continue to be extremely challenging to target. There are multiple novel agents that include PARP inhibitors, alkylating agents, VEGF inhibitors, and aurora kinase inhibitors that are currently being tested in both phase 1 and phase 2 setting. A brief mention is worthwhile for the first targeted therapy that was developed for small cell lung cancer. DLL3 initially appeared to be a promising target for small cell lung cancer, and the drug rovalpituzumab tesirine, an antibody drug conjugate, was tested with promising results in phase 1 study. However, in phase 2 study, with low rates of response and due to toxicity, it appears that the product has now been withdrawn from further testing. So looking to the future, what we hope additional clinical trials will give us insights into are the optimal sequencing of platinum doublet, IO, lurbinectedin, single agent chemotherapy, and how we can combine these drugs best and do that in the context of patients with varying degrees of platinum sensitivity in order to improve the lifespans of our patients with extensive stage small cell lung cancer.
plus something else. You know that from the lurbinectidine plus atezo is going to be a trial that is going to start within the next months as switch maintenance. And maybe this is the way I agree with Dr. Mitchell and Dr. Jain that probably we have to do something else better that way.
Thank you all. So we've got another question to Dr. Pons. Why do you think the Atlantis trial failed?
Good question. I think that one of the main issues is the dose of lurbinectidine. We are pretty sure, and we have data right now from the phase 1 that we did with lurbinectidine plus atezo. If we decrease the dose of lurbinectidine, it's slightly affecting the efficacy of lurbinectidine. So it's quite different using one dose or another. And keeping the dose intensity of lurbinectidine is crucial to get the benefit of that drug. So I think this is the reason, combining with toxo, that the dose intensity of lurbinectidine is not being so good as in monotherapy. That is the real reason of not having a benefit from that trial. That is the reason I truly believe that lurbinectidine is still a very good option in monotherapy at 3.2 milligrams per meter square, keeping that dose in the models that is already published, and then we will publish from atezo lurbinectidine trial. If we keep that dose, it's quite enough, and probably is the reason because Atlantis failed.
Okay, can I just ask a follow-up question on that? So in your practice, what do you use as second-line treatment for the platinum refractory patients? Do you use a single agent lurbinectidine, or do you do like combination of lurbinectidine plus irinotecan?
For those patients, I think that to my experience, we don't have a lot of patients, but the data coming from the phase 1 irinotecan plus lurbinectidine seems that for this tough population is quite good enough, I think, to go for this.
So you would do the single agent?
No, I would do combination.
Combination.
Irinotecan plus lurbinectidine.
But earlier you mentioned this, you were concerned about the dose reduction, right? Because with the lurbinectidine, is that something that you find is going to be a problem with the irinotecan combination as well?
No, because we have a synergy between irinotecan and lurbinectidine. It's not the issue. It's not the same issue that with doxorubicin, and it's not the issue with atezolizumab, because we have kind of synergies. So this is the reason I think we have this good data. One thing that I did once in my clinical practice was combining liposomal irinotecan that is available in Europe for pancreatic cancer plus lurbinectidine, because I think toxicity, hematological toxicity, is decreasing with liposomal formulation of irinotecan, and also data of liposomal irinotecan is super good. No, I have this experience also.
Okay, so this is something we can look forward to. We've got another question. Maybe I can take this. Is lurbinectidine approved by HSA for use in Singapore? Yes, for our Singapore audience, lurbinectidine is approved by HSA. It was approved in September this year, and in fact, if anyone wants to know, we had the Singapore experience with lurbinectidine. We had about 13 patients, and they were very heavily pre-treated patients, so they were not really your typical second line patients as you see in the trial. So some of them were the third line, some of them were fourth line, and out of the 13 patients, 8 patients had the combination lurbinectidine plus irinotecan. And generally what we found from the physicians who used it, they found that lurbinectidine was easy to use, and generally what we had, the progression-free survival was about 4 months or so, and that is for that 13 patients that we had as part of our compassionate access program. Yeah, we've got another question for Dr. Pons. Is the current trial with lurbinectidine plus atezolizumab first-line maintenance enough for US approval of lurbinectidine in second line of small cell lung cancer? Or will it be necessary to launch a new phase 3 trial with lurbinectedin to get the full approval?
No, actually, the advice of the FDA was to do this maintenance trial with immune therapy and to don't stop the indication in second line because of the data of the basket trial and this issue of the doses. Because of the Atlantis is not working, but we really believe that it's a matter of doses. It's not well designed, the trial actually. It's going to be enough with the maintenance trial and also the two small trial, the trial that I presented in second line in combination with immune therapy actually is in the landscape of keeping the approval by the FDA right now for second line and for a future for this trial.
Okay. Amit, you go ahead.
So, Dr. Santiago, it's wonderful hearing your insights on this. You're in the thick of it. You're planning new trials. What are you going to put your money on if you want to build your phase 3 trial? What's your combination of choice? There's so many ways to do this now.
Yeah. So if you had to pick one.
Phase 3, you mean for second line or for first line?
Second line.
Well, actually, I think that the second line. I'm not probably.
If you had to choose, if you have to choose one, we're having a gun to your head.
I have a bias probably, but with the experience that we have from the phase 1 Atiso plus lurbinectedin, having a very small number of patients, but having this control of the disease, and it's quite important that it's purely second line, because many times for small cell lung cancer, we are doing kind of patient selection if we allow to enroll second or further line, because all those patients being further line is a different small cell lung cancer. It's a small cell lung cancer that is alive. So those data from Lurbi Atiso is coming only for pure second line, only one line of platinum-based schema. No matter it was platinum plus radiotherapy.
Would the patients have had atezolizumab in the first line already?
Yeah, in the phase 2, we have two different cohorts, previously exposed to immune therapy and non-exposed to immune therapy. Each cohort with 80 patients.
Okay. And
so I will bet for immune plus chemotherapy.
Oh, plus.
Yeah.
Okay.
No, thank you for that. I mean, it's a slightly difficult question, to say the least. But it's very exciting to see early data.
Yeah, if we want to go farther, I don't know, maybe a crazy idea to combine MAG 757, that actually is a very good drug, and is changing the inflammation landscape of his immune cell, because it's a B-specific, and probably combining this B-specific with lurbinectedin can be a nice idea, actually.
And I'm just going to ask a quick question. You mentioned this thing about PD-L1 and in small cell lung cancer. Do you routinely test for that in your patients?
Yeah, we did, and we are now doing, because it's a procedure in our hospital. But I did also in a very big cohort, in a Spanish big cohort of more than 500 patients, small cell lung cancer, testing in our population PD-L1, because there are some series from China and some other series giving us a very high expression of PD-L1, but it's not our case, and we have less than 15% of patients being PD-L1 positive in this Caucasian cohort of small cell lung cancer.
And on that same note, right? Do you rebiopsy, or do you routinely rebiopsy your patients who progress on first line or second line for that matter? You do.
Yes, normally yes. Looking after probably genes of the reparation of the DNA alteration to enroll those patients in trials, not from a standard way for patient to be treated with any drug in second, third, fourth line, but searching those kind of alterations to have some chance to enroll in PARP inhibitor plus immune therapy trials.
Okay, we've got a question for Dr. Mitchell as well. How important is the maintenance IO in first-line small cell lung cancer?
Okay, I'll answer that in a minute. I'll just add to the previous conversation there. We looked at, we have a TMA of small cells, about 160 or 70 cases. And by and large, we were seeing a lot of PD-L1 expression in the immune infiltrate and very little in the tumour cells. Seems to be the sort of usual pattern. We weren't able to specifically relate that to the outcomes for those patients because the outcome data wasn't good enough. But I think that's a common observation. The question about maintenance IO, just if you put it around the other way, I think generally if you're using maintenance only, that's not a proven approach in small cell yet. The trials have been negative, including the Stimuli trial. And I certainly wouldn't be doing trials where I was looking at it only in maintenance or only concurrent. It just doesn't make any sense. We've got the data from the extensive stage patients where there is a clear benefit. And so somebody might want to test that sometime in terms of just giving 3 or 4 months of immunotherapy without the maintenance. But I think that's probably likely to be fairly ineffective. The other thing is that the curves separate sort of after about 5-6 months around there. So it's hard to see where you're getting a substantial effect early on, but I think probably the concurrence sort of sets up the environment for the later benefit.
Okay, and to follow on with that, let's say, for example, if you have a patient who, let's say extensive stage small cell lung cancer and had just had etoposide carboplatin as first line and they progress without any immune checkpoint inhibitor, or a similar situation where limited stage lung cancer had concurrent chemo RT and progressed within 3 months and haven't seen immune checkpoint inhibitors and they are platinum refractory. So what will be your choice for second line therapy? Would you consider using your immune checkpoint inhibitors in the second line, or would you still go back to your standard second line chemotherapy options?
Yeah, I mean, it's attractive to try it, but the reality is that the trials have been negative. And so if you're going to try that, maybe it's in the context of something novel, a novel combination or something. Of course, second, third
like the lurbinectedin and atezolizumab.
Clinical trials, so it's a difficult population to really get good results, and often they're only surviving for a few months. So very, very difficult area. I think that really we're probably going to make more inroads into perhaps dual immunotherapy type approaches with some of the newer approaches that are starting to look a bit interesting in non-small cell. And I'd like to certainly see a limited stage small cell, though, as I say, I think in Australia the proportion of limited stage is normally about a third, and I think at the moment for us it's probably less than 10% due to the late presentation, I think. But anyway, I think the 3 out of 4, 2 out of 3 of the existing ongoing limited stage do have concurrent and maintenance, one of them just maintenance only. So my money would be on the concurrent plus maintenance as being the way to go.
Okay. Amit, we have a question for you as well. Why did you use temozolomide for the patient that you mentioned in the case study? Why not another chemotherapy regimen?
Sorry, what was that? Sorry.
No, this is regarding the case report that I just presented briefly, and in the second line setting, what I offered my patient was temozolomide. And so the question is, why did I choose this?
It's one of the options that is listed in NCCN, right? So why do you choose that?
Well, it might have been flavor of the season, and it was definitely directed by patient choice. He didn't want to be tied to hospital visits at this point in his life. He felt like he'd reached a point where he wanted the simplest possible treatment. He wanted something oral. He didn't want to be tied to chemotherapy suites. So then looking through the oral options, and there was some unequivocal spots in his brain. And so I was wondering about, whether I needed something that had some class effect for brain penetration. And those are some of the factors that went into choosing this. And of course, his tolerability, which proved to be okay. I didn't expect any response, but he did have a partial response. So that was pretty nice to see. I guess then the other thing at the back of my mind, thinking about small cell lung cancer and looking at what happens second line onwards, is always concern about how well we're getting into the brain, because so many patients will end up having CNS failure. So I thought I'd lead to another question and ask the panel here what they thought about how that's going to be addressed in the future.
Your question is, how is the brain penetrability of all the drugs going to be, is it?
Yes.
Okay. Dr. Santiago?
So I have firstly one point for the temozolomide.
Okay.
Do you use it as well?
Not normally. It's I've been using sometimes, but it's not regular. But something that's quite interesting from temozolomide is if thereafter if you have a still patient after progressing to temozolomide or giving a courses of temozolomide, if you double check the tumor mutational burden, and the tumor mutational burden can change a lot. Actually, temozolomide can change the immune landscape in every single tumor, but also in small cell lung cancer. We have some cases of a small cell receiving temozolomide and the changing of the TMB, and then enrolling patients in immune therapy trials and having some nice responses because of that. So maybe it's not a full idea of giving temozolomide and thereafter checking if the landscape is changing as a comment. And to address the question of brain mets, I think it's really complicated. Actually, we decided to do the design of the Caspian trial, actually allowing brain mets untreated without radiotherapy, because I think brain mets is one of the issues that we have in small cell lung cancer. Actually, I don't know, maybe this strategy of the anti-angiogenic treatment that we mentioned in second line from this Chinese trial also, I don't know, maybe the angiogenesis can actually be better explored if we can improve the density of drugs within the brain using anti-angiogenic. We have this experience from some other cases in non-small cell lung cancer, so I think maybe that we may better.
And just to follow on with another question to Dr. Pons, do you have any data on the CNS activity of lurbinectedin?
No, not yet.
But just based on your clinical experience, what do you think? Do you think that it helps patients with brain mets?
Yeah, we don't have still with a measure that we can show, but yes, I have clinical experience of patients having brain mets and good control. But being honest, I can't give you right now data.
Okay. And to Dr. Mitchell, I think you mentioned the role, you were speaking a bit of consolidation radiotherapy in extensive stage small cell lung cancer. So there's the question to you. Do you often offer local therapy after response to etoposide platinum and plus immune checkpoint inhibitors? What do you think about the role of local radiotherapy in this case?
Yeah, so that really goes to the trial that we're running at the moment. There is some effect, as I indicated in my presentation, about therapy in limited extensive stage small cell. But I'm more interested in the potential benefit of mediastinal radiation in terms of trying to, I suppose, have some effect on the immune response against the cancer. Ultimately, yes, there's a local effect which is fairly modest, but I'd be more interested in whether adding radiotherapy might enhance the immune response.
In your trial, you're giving the radiotherapy concurrently with the chemotherapy, or after the initial?
I think if you're going to try, theoretically, I think that if you're going to try and use radiotherapy in this way, it should be concurrent.
Okay, and so far in your trial, do you find that very difficult for the patients to tolerate, or it's okay?
We've only just opened a week ago, so can't tell you.
Okay, maybe down the road we'll hear some data from that. And we've got another question. What is the most promising biomarker in small cell lung cancer according to you? Maybe we'll just go around the room. Amit?
Well, if I was going to take a long view, I think if we look at how P53 and RB1 or MYC, I would pick MYC as something that is a difficult, but because it's so ubiquitous, but that's a dream target. And I think I'll let the other speakers pick the more relevant targets.
Dr. Mitchell?
I think the data on, I mean, it's only a small group, but inflamed group of tumours, I think we should try and work with, in the first instance anyway, to try and improve the therapies.
Dr.
I suppose the other thing from that too, with the Empower 150 regimen, non-small cell, whether their strategies like bevacizumab might have an effect there. It's possible.
Yeah, I agree. No, it's a tough field, but I agree with Dr. Mitchell.
And let's say, I mean, maybe we can do this last question. Let's say if you were doing this, having this webinar 5 years down the road, do you think we will be still talking about overall survival being about slightly more than a year, or do you see things changing tremendously? What are your views? Maybe we'll start with Dr. Mitchell, and then we can go around the room. That's not very that's
tremendously is a very hard work for small cell lung cancer.
That's not very encouraging that we're all quiet.
I change that word.
I'd be confident we have some effects. We've made some more significant progress. I mean, the addition of immunotherapy is really the first major benefit for overall survival really since chemotherapy was used. So we shouldn't dismiss that, but I think it's probably a 10-year plan rather than a 5-year plan.
Okay, so if it's 10 years, do you think we would have doubled the overall survival? No? Amit is the optimist. No. Let's ask him.
No, taking into account the last 30 years that we have like more than 40 phase 3 trials failing, improving anything in small cell lung cancer, I'm saying that I'm positive, and I think that with the immune therapy and probably PD-L1 is the first in the room, but not only different smart strategies, combinations, and so on. I think we can expect. I don't know if maybe doubling. But I think we are in the good road to improve. No, moreover, because we are, and one of the points that you did mention is that we have to biopsy and rebiopsy patients, even with small cell lung cancer, because we are treating all of the patients of small cell lung cancer like the same disease, and we know already that it's not the same disease. So we have to start doing this. I know that this is a very difficult disease. Patients are normally in not very good conditions, but if we want to help those patients, we have to do this effort, to biopsy, and biopsy. If not, it's going to be very difficult to double these overall survival rates.
Okay. Thank you all for the excellent discussion. I really learned a lot, and I really enjoyed myself. But I think it's time for us to wrap up. So with this, I will end our webinar here. So I'd like to thank all our speakers today. Thank you for the excellent presentations, and also like to thank Specialized Therapeutics for putting together this webinar for us and inviting myself here. So all of you, so have a great evening. And just before you leave, remember to scan the code at the end of the webinar. You can get your e-certificate, and for those who want your CME attendance, you can you can scan the barcode as well. So thank you all, and have a great evening.
Good day.
Thank you.
Bye-bye.
Thank you so much.
Thank you.